record this lecture, even though the audio quality isn't that great. Sorry about that. I think my my boom mic is broken. I've got a new one coming in. But is anyone actually listening to the recorded audio? Should I keep doing it? Yeah? All right, so I'll keep doing it if I keep remembering. Funny thing happened. So last night I actually gave a guest lecture in the Carleton University equivalent of this course. It's a fourth-year global health course. And guess how many students they have in that class? Five. That was fun. I felt really, makes people here complaining about being close to me. Imagine 5 of you, like, this close. You know what I had for dinner? Just shawarma. You can smell that, right? Yeah. Okay, right on. Let's keep going here. So today we enter one of a couple of lectures that are kind of really similar to what you're going to get in epidemiology, because I do duplicate some stuff. So don't be surprised, those of you in my epi class, if you see exactly the same slides in a couple of weeks in epi, because why fix perfection, right? So because a lot of international health is epidemiology, and in order to understand how to measure and understand the burden of certain issues, we need to understand how to measure them and why we're measuring them. And we have a variety of tools for measurement. Before I start, though, I mentioned last class that we have some SAS students who require individuals to step forward and volunteer as note takers for this class. It would be great if people could volunteer to do so. I've created a survey online if you want to volunteer your services. That would be greatly appreciated. Just click on that, and there's a link in the announcement section already. And as well, 23 of you have done the pre-class questionnaire. I appreciate that. If you want to do it, it's still available. I'll keep it up until the end of the week. Again, it's not part of the course. You're not being marked on it. I don't know who you are. It's anonymous. It's just a thing that we do. It's kind of fun, maybe. We'll find out. So if you want to finish it, it's there until the end of the week. All right. Let us begin. I take you now to the center of the universe, the island nation of Dionandia, at the center of the world. It is a lovely nation, surrounded by palm trees and fruits. It's also a basket nation run by a tyrannical king, and that's his handsome face there at the crown. And the thing about the island nation of Dionandia is that his tyrannical king needs data, because he's not very clever. He needs advisors. And all of you are the ministers of health for Dionandia. And so I, the king of Dionandia, are calling upon you to assist me in making a decision. So we know that the top diseases in Dionandia are cooties, malaria, and diabetes. Cooties is a real thing, by the way. Cooties is lice. That's where it comes from. Yeah. So I only have enough money to really address one of these diseases in the current year, and I need to make a decision. So what information do you think, as my Minister of Health, we need to collect to make that decision? Give me some examples. What do I need to know in order to decide which disease to focus my limited monies on? Yes. Prevalence. Very good. What's prevalence?
The total number of cases?
Sure, that's close enough. Look at you guys. You're all so well-versed in this stuff. When I started teaching this class 9 years ago, no one knew these words. Now by the time you come to me, you're all seasoned vets, which is good. So prevalence is one thing you might care about. What else do we care about? Yeah. Sure. What's incidence? That's exactly right. Okay. What else do we care about? Yeah. Of course. If people have read the chapter and you've done some study, good for you. Yeah, absolutely, because we care about what's killing people. Because if the most prevalent incident diseases are like the common cold, as they probably are, who cares? That's not a reason to spend money on it. But if it's killing people, okay, we have an argument now. What else do I care about? What do you mean by that? Okay, so there are infectivity and things like that, yeah. Yeah, that's good. If it's highly mortatious, mortalitous, more fatal disease, but it's hard to get, then it's not that big a deal. What else do I care about? Yeah. What do you mean by that? Chronic. Is it preventable? Is it behavioral versus infectious? Sure. Sure. What else? One more time. What else? Yeah. Oh, look at that. Economics. Yeah, now we're getting to the good stuff. And that's kind of what we always care about the most, to be honest. because ultimately this is all about money. We started out talking about money. What can I afford to treat? Therefore, what's costing me the most? What's the biggest bang for my buck? All right, all good answers. Excellent start. And you're not, well, I wouldn't hire you as my ministers of health. I could hire you as my interns of health. So that's not bad. So what we're talking about here is a collection of what we call indicators. Indicators. And indicators really are the fundament of the measurement of population health. Entire careers are built on the design, collection, interpretation of indicators. There are institutes that are just all about collection, refining, defining indicators. You can go to the UN website and look at literally thousands of different kinds of indicators. We can sit here today and invent brand new indicators if we want. Right? I had a study a couple years ago. We looked at measurements of female empowerment in Arab countries. We have indicators for that. For example, how many women are in parliament, right? How many women go to school, that kind of thing. Those are, in theory, measurements of female accomplishment in societies. Right? So you can do all kinds of fancy things with indicators. So what is an indicator? It is, here's a definition, it's a statistical value that provides indication of a condition, blah, 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 blah. It's a number. So it's a number. Okay? Is it always a number? Sometimes it's a quality. Health is good. That's an indicator. But in general, no. It's usually some kind of measurement. So a famous indicator in Bhutan is the gross national happiness. You ever heard of that? Okay. So we probably talked about that a lot in the past. But how do you measure gross national happiness? It's a tough one. At the same time, how do you measure wealth? That's tough as well, but we figured out ways. So Bhutan has a multi-dimensional system involving opinions and interviews and things like that. Right? So we'll go back to that later on. So why do we have indicators in population health? We want to monitor which diseases are affecting the population. What does affect mean? Affect can mean killing, making ill, keeping out of school or work, making you miserable, all kinds of things, depending on what you care about. Monitor the extent to which programs are succeeding. All right, now we're into the nitty-gritty, because that's really how it's applied in real life, is do we have indicators for evaluation? We're going to evaluate this program. Health Sciences undergrad program gets evaluated every few years. It was actually evaluated last year by the government. And they send observers, and they talk to professors, and we lie to their teeth and all that shit. Oh, it's a great program. No, it's not. Sure it is. No, it's not. Maybe. And but then they'll have their own indicators for success, like how many students are graduated, how happy are the students when they graduate, what proportion of students who begin the program finish the program, what jobs do students have when they graduate, do they have jobs, how much money they make when they graduate, all that wonderful stuff. So those are the indicators of success that they have chosen for this program. Similarly, every international health program has an indicator that we think is associated with it. That could be things like HIV, prevalence of HIV, right? So if your program is meant to reduce the burden of HIV, then preferably between when you start the program and end the program, the measurements of HIV in the population should have changed. And it can change for better or worse. Sometimes if it changes for the worse, it means your program is actually working. We'll see how that works in a second. But monitoring is a big part of this. And to inform decision-making, which is how we started out this lecture, of the mad king of Dionandia asking for advice of how to guide his policy decisions. Don't worry about that. I'm showing you that you can look up indicators in PubMed so you're blue in the face because there's endless papers about it. Here we have global monitoring of changes in health, blah, 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 blah. We talk about it endlessly. What's the best ways to measure these things? The problem is, how do you know which ones to use? And this is where you can get really caught up in your own agendas and miss the forest for the trees and things like that. You remember from your evaluation class, I'm assuming people still take program evaluation. Some people do. Yeah, maybe. So you remember process indicators versus outcome indicators and impact and all that shit? If not, if you're evaluating this class, for example, a process indicator would be the number of people that took the class. An output indicator would be the number of people that finished the class. An outcome or impact indicator would be something like, at the end, how many people feel that they learned something in the class. So it depends on what it is I'm trying to measure, what is the story I'm trying to tell. Process, output, impact, all this stuff matters. Okay, so here's some examples. In Dionandia, last year's mortality rates, Crude constitute 8% of all fatalities, another 2%. So based on this, The most dangerous or important disease, I think we'd agree, would be cooties. Of all the things that kill people, cooties kills 8%. That's serious. But we have this new thing called OFART disease. So OFART disease is 100% fatal to people over 65, but not very fatal to those under 65. But it accounts for 10% of all the fatalities. Would you agree then that OFART disease is more important than cooties, given that 10 is bigger than 8? Why or why not? Yeah? It's based on the number. That's true. Right. What if I tell you there's an even distribution of elderly and young people? Does that change your impression? You're absolutely right, by the way. That's the first level of analysis, is exactly how many people we're talking about. I guess it comes down to, do you care about OFARTs? Right? Now, in our hearts, of course we do. I'm almost one. I care about me. Yeah. But governments care about productivity. So one could argue that something that affects old people is not as important for decision-making purposes at the population level as something that affects young people. That's a recurring theme we'll see as we assess population health, is that we care more about especially the extremely young than about the extremely old. Why? I think the reasons are obvious. Right? They're going to die anyway. Knock on fake wood, but they're probably retired, less economically active. Okay. So there's that. So choosing that example was just an example showing that it depends on your values, and you have to ask yourself, what is it you are trying to measure? A lot of this is qualitative and personal and subjective. Right? You have to really interrogate yourself. What is the story I'm really trying to tell here? So choosing your indicator depends on what it is you are trying to measure. Chickens, babies, or fish. Right? How many are dying? How many are suffering? What's it costing? Which is the fastest growing? All these are different questions that require a different indicator. So one measurement does not fit all. And you'll see media make this error all the time, like Ebola. The horrific stories around Ebola. Well, yes, it's a bad disease. It kills some people. It's scary. It wasn't really that big a deal at a global level because you're not going to get it. Okay, so I did some radio interviews at the time, and journalists are terrified. Should we be scared? No, you shouldn't be scared. You're not going to get it. Believe it, you're not going to get it. Right. So even though it's highly fatal and infectious, your likelihood of getting it is quite small, and dying from it is quite small. Okay, so here are some pragmatic aspects of indicator use, because we need to make this as scientific as possible. I'd suggest to you there are 4 dimensions of a good indicator. It must be well-defined, must be valid, feasible, and have high utility. So is it well-defined? Let's talk about happiness. So you're measuring happiness. And I say to you, on a scale of 1 to 5, how happy are you today? Sorry? Yeah, sure. I'll give you a number. Oh, look at you. That's fantastic. I didn't tell you a 5 is happier and 1 isn't. So that wasn't well-defined. Right? And what does it mean to be happy? I don't know. Right? It could be content. It could be this minute. It could be your life in general. It's not well scoped out or defined. Valid. All right. Let's say, because I can't ask everybody in the nation how happy they are and collect the average. It's not. I can't afford to do that. So say instead, I'm going to assume if you have a job, you are happy. So I'm going to say the employment rate is in fact a happiness rate. Is that valid? Probably not. We all know some employed, unhappy people. In fact, most people who are employed are unhappy. The act of being employed makes you unhappy. Okay? So that would be an invalid assumption to make. Validity is whether or not the indicator measures the thing it says it's measuring. Give me an example here. For the same token, I can look at wealth. We like to measure, BMI is a great one. Okay, is BMI really a valid measurement of obesity? I would say no, it isn't, because I'm actually technically obese according to BMI measurements. I'm not obese. Look at me, I'm ripped. Right? But bone density and muscle mass kind of skews that impression. So that's validity. Feasibility. So is it possible to do what you say you're going to do? So if I'm measuring happiness again, I could, to make a perfect indicator, I could actually interview every one of the citizens of Canada. Sit you down for an hour, talk about your life, your hopes and dreams, how much you've done. I can measure the cortisol levels in your blood. I can do all kinds of fancy stuff and compute some multifaceted score. I can't do that. That's not feasible. right? It's not affordable. So feasibility is a problem. That would be a fantastically valid measurement of happiness, but it's not feasible. And utility. Do I care about measuring happiness? Is it really useful for my decision-making process? You could argue that it is, right? But I can measure how stinky are your farts. That could be my indicators that we collect in the next census, right? Age, gender, location, postal code, fart stinkiness is not a useful thing to measure. So those are the 4 dimensions that we care about. It's fairly political, too, measuring indicators, and different countries do it differently. There are endless frameworks for defining and selecting them, and if you want to make a career out of this, it's there for the taking. So this is something that people actually build. It sounds boring, I know, but it isn't. It's actually kind of fun. Okay, so if you want to read about it, Canada actually has a system for making its own indicators. In Canada, we have 5 categories of health indicators. Status, let's go through them. Health status, that tells us, how healthy people actually are. The determinants of health that you all know about because that's been shoved down your throat in first and second years endlessly. So, by the way, that stuff is still revolutionary to most of the world, but for you it's second nature now. So health system performance. Let's go through some examples of this. Do I have examples? Oh, I have examples on the next slide. Here we go. Health status. So something a bit like how many cases of this there are. Prevalence of breast cancer. A non-medical determinant of health. Here's the example of smoking rate. We can also say employment rate or education rate. Those are more, distal to the issue of health, but smoking is pretty proximal. Performance indicators would be like wait times, how many doctors there are in your area. Is there a co-payment to access health services? Is there a road to get to the clinic? Do you have mandatory prenatal testing in your area? That sort of thing. Community and health system characteristics. So that's how we describe the population, or some measurement we can make of the population that has some ancillary connection to health. The example I've given here is population density. We can even do something like gender parity. Are there equivalent numbers of men and women, more or less? Because some populations don't, and that makes them problematic. Equity is a tough one. Equity is something that's very Canadian, and no other country really measures this, maybe New Zealand. So I don't really fully understand it. But it's something about the example I've given here. So if this population were as wealthy as that population, what difference in smoking rates would there still be? What difference in health rates would there still be? That kind of stuff. So it's a measurement of equivalizing or equivalating, whatever the right word might be, various determinants of health. So I don't fully understand it to describe it well. Therefore, I'm not going to test you on it probably. That's the way that works. But I just be aware it exists. Did I say it out loud? No, I did not. You didn't hear me say that. Okay, so let's talk about some of the traditional indicators of population health. And again, this is the epi stuff that you hear more and more again, and you've already seen this in stats class and research methods and other places, I'm sure. So this hopefully is some degree of review. So mortality is death. So the general crude mortality rate is the total number of people who have died divided by the total number of people who are at risk of dying. Who's at risk of dying? The living, right? But not the undead, just the living. So we usually give this as a rate per 100,000. There's some old-fashioned traditions we have in population health or how to report these things. I just ignore those traditions. Percentages are fine. Why mess around? Percentages are fine. All right, here's an example. In 2000, malaria mortality rate in Djibouti. That would be great if the capital of Djibouti was Sheikh. Yeah? Think about it. It'd be fantastic. Djibouti was, so that's an example. If you didn't get that, don't worry about it. Just move on. Okay. We can break down mortality rate into like 1,000 different categories. We'll talk about a couple of the key ones right now. We have standardized mortality, which we will not be doing in this class. We will be doing it in epidemiology, which is a very important epi skill to have, is standardization. So don't worry about it here. But we're going to do a couple in this class, right? The first one is the case fatality rate. So this is the number of deaths from a given disease divided by the number of people who got that disease. In other words, it's a measurement of the scariness of that disease. If you get the disease, how likely is it you're going to die? So the CFR for Ebola prior to the most recent outbreak, so last year, was 90%. It went down. Why did it go down? How could it possibly go down? How does the CFR of a disease go down? What are some of the factors that influence whether or not a disease is going to kill you? Yep. Okay, but why are fewer people dying? Fewer, not less. Come on, grammar side yourself. Yeah. That's one of them. And you're going to say? Treatment and prevention. All of it. The more you learn about the disease, the better you can prevent people from dying from it. Simple as that. The less people die. So, like the common colds that have a high CFR 200 years ago, now it's pretty much zero. So, Ebola wasn't on anyone's serious radar until the recent outbreak, and so suddenly a lot of resources are thrown at it, and the CFR comes down. So CFRs are variable depending upon resources and experience. So again, that doesn't mean you're going to get the disease. In fact, with Ebola, you're not going to get it. I guarantee none of you are. And if I'm wrong, you're not going to be around to sue me, so that's fine. But if you get it, you're going to die. So just don't get it. Okay. Whereas the PMR is the proportionate mortality rate. So this is, of all the people who died, how many died of that disease? Okay. So it's more of a population level look at things. So here, Sub-Saharan Africa, the PMR from heart disease is 10% of all deaths. And coronary heart disease is 3% of all deaths. Right? So right there we have a decision-making parameter. I know that at a budgetary level, I probably should care more about cardiovascular disease and coronary heart disease. So what if almost nobody is dying in that population? Then these numbers are kind of meaningless. It just means they're a tiny fraction of a tiny fraction. On the other hand, if we have a healthy or a standard number of deaths, then these numbers mean something. So keep in mind these are always rates and ratios. So what's this? Sorry about that. Just comparing, this was OFART diseases before, so I'll skip through that. Okay, so in essence, when choosing an indicator, you're asking, what is it I'm truly trying to measure? Am I measuring how scary a disease is? How likely am I to get it, which is like prevalence? Right? The risk of a population experience it, which is like incidence? Or am I measuring something else? Right? What's it costing? What's it cost if I don't address it? Opportunity cost, et cetera, et cetera, et cetera. We are going to talk a lot about poverty on Thursday, because poverty is a fun topic for measurement. So I'm going to skim over it pretty fast right now. There are lots of ways of measuring poverty, and one of the fun things I like to start out when I talk about this to the general public who aren't, science students, is the percentage of children living under the poverty line in Canada is, according to some people, higher than the percentage of children living under the poverty line in Bolivia. Therefore, is Bolivia a richer nation than Canada? The answer is obviously no. Nobody in any right mind would say that Canada is poorer than Bolivia. Then why do we have that statistic? The answer is that we define poverty differently. Right? So there are literally scores of different ways of defining poverty. So when the media says, these people in the parliament, what do they mean by it? Right? And on Thursday we're going to go over in detail all the different ways of measuring poverty. That sounds horribly boring, but I don't think so. I think it's kind of fun. Okay, so the most commonly or most rational, reflexive way of thinking about poverty is all the stuff that you need subtracted from how much money you actually have. And that gives you like a negative number, then you're impoverished. If that gives you some kind of saving, then you're probably, at least surviving. Okay, there's an article that I did before. I don't remember. It doesn't matter. There's math in it. The takeaway message of the article is there are new ways all the time of defining poverty. And again, Thursday we're going to go deep into those woods. In general, one standard definition of poverty is the minimum level of income necessary to achieve an adequate standard of living. Do you see the qualitative aspects of that definition? Is there an element of that definition you would like further clarity on? Do you see something? Yes. What is adequate? Absolutely. And what else? Minimum, sure. What? What's the standard of living? Right? Like, what do you? I'll share on Thursday. The Americans only care about food, according to their definition. They calculate poverty based on can you afford food, right? More countries look at can you afford shelter. Some look at can you afford food, shelter, and education. Food, shelter, education, and fuel. Now we're talking about food, shelter, education, fuel, and internet, believe it or not, right? So becomes a very complicated discussion very fast. What is the necessary or adequate resources needed to thrive in today's modern environment? Is it adequate to talk about survival, or must we talk about thriving? Right? So one could argue that simple survival is, you're not doing them any favors. Right? You have to sort of allow people to somehow be in a position to raise themselves up in the world. So all these definitions vary between countries and over time. Yes? Yeah, absolutely right. Absolutely right. That's right. So what the battle we have here in defining poverty is in completion, comprehensiveness, and feasibility. What should we be measuring, and what can we measure? And we'll see on Thursday that most of the global definitions settle down to three domains: some measurement of education, some measurement of wealth, and some measurement of food. Right, and how those interplay. But more people are saying, yeah, we need behavioral things, economic things. We'll see it on Thursday. But I want to tease you right now by bringing up the ideas of relative versus absolute measurement. But I will say, though, that the biggest cost that most people in the world will ever endure is their shelter. Right, rent is the biggest thing you'll ever pay. Probably the most expensive thing you will ever buy in your life is what? Come on, be brave. Volunteer it. Yeah. Not your house, but... In your case, maybe, yeah. These days, prices, yeah? Your mortgage, right. It's a lot more expensive than your house. Okay? Well, yeah, okay. Unless you harvest their organs. I'm telling you. Pay for themselves that way. Say it out loud? That's a problem. Okay. The reason I have kids. So, all right. Well, this is the article I was going to show you. Don't worry about it so much. It talks about a new poverty index that we will talk more about on Thursday. So I do want to talk about relative versus absolute poverty, though. And this is something the media conflates a lot. Relative poverty defines poverty relative to an internal threshold, internal point. Absolute poverty is poverty relative to an external point. Now, sometimes we talk about absolute poverty as that man lives in absolute poverty. That's not what we're talking about here. We're talking about an actual measurement here. Let's see if I got slides here. So here's an example. The European Union uses a relative poverty measure. In Canada, we use one as well. Ours is complicated. It's called the Lycos Score. We'll talk about the Lycos Score on Thursday. But the European Union does this. If you make under 60% of the median income, then you are living in poverty. Okay. Now, let's say you are living in a land of millionaires. Is there a country like that? Brunei. Why not? Brunei is a wealthy country where most people are rich. Right? There's always going to be somebody making less than 60% of the median. So if you're a land of millionaires, if you're one of the poor millionaires, you're impoverished. Makes no sense. But that's the danger of a relative measure, is that somebody always has to be impoverished according to a relative measure. So it's difficult to see positive changes over time that way. On the other hand, absolute measurement is really hard to operationalize because absolute poverty says, I don't make enough to get this basket of goods that are deemed necessary for me to thrive. And I use those terms intentionally. Basket of goods is an economics term. So the basket method is one of the absolute methods that's used. Okay, so what is a basket of goods? It's a basic human needs: food, safe drinking water, sanitation, blah, 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 blah. So it's not just income, but also access to stuff. So we're going to do more about that next class. There have been several attempts to operationalize both relative and absolute poverty, and I want you to see some stumbling blocks of how we think about this stuff, because it's complicated and fun. But I want you to be aware that different countries have different methods, different organizations have different methods. If you're comparing two papers talking about world poverty levels, they guarantee to use different methods. All methods are flawed, and beware of these blanket statements like this country is more poor than that country. It may mean different things. Okay, moving on. Prevalence, you all know what that is. You've covered that in previous classes, I'm sure. This is the percentage of people who have a certain disease or condition. Right? Prevalence and incidence are measurements of what we call morbidity as opposed to mortality. Morbidity is stuff that's not killing you but making you miserable. Mortality is stuff that's killing you. So we usually give it as a percent. So prevalence of what, among whom, where, and when. In Panama, 95, prevalence of HIV is 0.9% of the adult population over 15 years. Right? So it's important to give these other dimensions so we understand what's going on. Incidence, as you know, because you're all good health science students, means new cases. And again, media conflates those terms. Do not conflate those terms. Okay? So it is the rate of new cases of a given disease over a period of time. Now, as you'll see in epidemiology, an important distinction is that the denominator of prevalence is everybody in the population, including those who have the disease. Amongst incidence, the denominator is people who don't already yet have the disease. So that means, instance, in an epidemic scenario, incidence will probably increase as the denominator shrinks, people who don't yet have it. Okay. Again, that's more of an epi thing, not so much a health, international health thing. Traditionally, we report it as a rate per 1,000 people, but who cares? Percentage is fine. People get really anal about this stuff. In Uganda, incidence of HIV fell from blah to blah. Okay, look at this stat here. In Uganda, incidence of HIV fell from among adults fell from 7.6 to 93.2. All right, that's fantastic. That's true. Right? It actually did that. Does that mean that the burden of HIV/AIDS in Uganda went down in that period? Does that mean that the suffering of people went down in that period, or their AIDS issue went down in that period? Yeah? That's right. So the number of new cases is shrinking, but you're still getting new cases. And unless they died, those old cases are still there. So you're mounting cases still, you're just mounting them more slowly. So definitely, in 1998, there are more people with HIV/AIDS than in 1990, unless they died. In fact, they probably did die back then. Right? So beware of interpreting incidence change as a change for the better necessarily. It just means that we're slowing down the growth, but the burden is actually increasing sometimes. So I show this graph in absolutely every class that I teach, and I'm guaranteed that some of you have seen this already. Here we have the epi class, we showed this already. So new AIDS cases, or HIV cases, new AIDS cases, actually cases of transition HIV to AIDS over time. So 1990, in North America, they came down dramatically. Why they come down dramatically? Who knows? What happened in 1990s? Anybody remember? You guys weren't born yet, were you? God damn it. So in 1993, 4, 5, 6, important technological innovation happened. The antiretroviral cocktail was developed. So suddenly HIV became a chronic condition, and people weren't dying of AIDS anymore, getting AIDS, or staying with HIV. The Caribbean, the cases increased. Why do they increase? Yes. Exactly. This is detection bias. We saw more cases. And I tell the story all the time. You've heard the story before, but there's a project that I was working on, CETA funded, that was meant to address HIV/AIDS in a certain Caribbean nation. And the project was going to build new laboratories and detection protocols for HIV/AIDS cases, but also have a prevention strategy. And we had to propose indicators for measuring the success of a program for the funder. The indicator that was proposed was new AIDS cases and new HIV cases as well. We're going to bring them down by this % in 5 years. I had to put up my hands. It's not going to happen. You're going to have detection bias, because the more labs you build, the more cases you're going to find. So you're setting yourself up for failure, and you have to be aware of that. We didn't fail. We weren't going to fail. It's just that there's more cases than you think. So you have to be aware of that at all times, especially when you're using indicators to assess success of things. Okay, let's move on to child health. Let's drink some coconut juice. Coconut juice. Shouldn't it be coconut water? They had sugar to this thing? Is there sugar in this? Oh, bastards. Yeah. Okay. The term neonatal means having to do with newborns, and we define newborns usually in the first 28 days of life. perinatal means having to do around the time of birth. We say 5 months before and 1 month after. So perinatal can refer to the mother as well, not just the newborn. Infant is people under 1 year old. Right? So infant mortality rates are quite high in struggling countries. That's why many cultures historically actually don't name their babies until their first birthday. Because why? Name something that's likely going to die. So the naming ceremony becomes important over time culturally. We measure infant mortality as one of the very important indicators of population health. Do you know why? Why is infant mortality so critical? Yes? Yeah, okay. I think you're up there, and so using this to measure one indicator to measure the other indicator. No. That's right. Yeah. Sorry? You're the youngest. Okay, you're all kind of saying more or less the same thing. I thought you were going to say because of the most delicious of that age. It's true. It's because most human societies seek to protect innately, anthropologically, certain demographics, pregnant women and freshly born babies. And they're easy to protect medically by, having adequate food, good hygiene, prenatal care. Those are actually fairly inexpensive, easy things to do, comparatively. So if you cannot do those easy things that everybody wants to do, something's really screwed up. So those should be easily addressed indicators. And if you're failing there, then there's profound problems on the ground in your system. That's probably the main reason, in my opinion, that we collect those data. And child is defined as someone under 5. So reduction of child and infant mortality was one of the MDGs. Now that's been rolled over into a more comprehensive measurement for the SDGs. So the biggest killers of children are these. I've included HIV/AIDS as number 6 rather than being top 5 because if I talk to the general public, someone always says HIV/AIDS. I want them to know it's not in the top 5. It's top 6. There is something about these diseases, and you can see it right here. They're preventable. These are all preventable or treatable. There's nothing extraordinary or mystical about these diseases. Like preterm birth issues, these are all infection issues that could be avoided with perinatal care. More infection issues. Diarrhea is avoided with hand washing and other kinds of hygienic interventions, clean water. Malaria is avoided by avoiding standing water. Measles vaccine, etc., etc., etc. So the fact that the things that kill children the most are largely avoidable is worrisome. Okay. And most of these things happen in the same handful of countries. In these countries, India, Nigeria, Congo, Pakistan, and China. Now this is changing rapidly, and I fully expect these numbers to be profoundly different in 5 years. So in a good way. I don't know why I've done this twice, but you get to see it twice. That's great. Okay. Yeah, that's not very useful. So there are gender splits as well in child health. So in 2011, we had 53 dead boys per 1,000 live births and 50 dead girls per 1,000 live births. But it's actually down from 1990. So dramatic progress has been made. Look at these incredible numbers here, 89 to 53, 85 to 50. That's positive. And that's a result, many would argue, of the incredible investments made as a result of the MDGs. Right? People said we're going to focus on these issues. The MDGs have said that one of our goals is addressing child mortality, so a lot of these programs we focused on this in those key areas, and it worked. Other arguments would say that, yes? That's what I'm getting at, right? Very good point. No, it's not globally, right? A lot of the positive change that you will perceive, and by the way, I'm going to talk about this in the talk I give at the AGHN on September 20th. Is that right, Sharon? What's the date? 28th? 30th, really? Will I come on the wrong day? That'd be embarrassing. Okay, cool. 30th? That's a Sunday, Saturday? What is that? So the AGHN conference, which you were all invited to, the talk I will give will be on something of this nature. Are things getting better or worse? Now, in many ways, things are getting better. However, it's not getting better everywhere. And there is an argument to say that the miracle of a couple of nations is pushing all of this. What couple of nations am I talking about? 2 nations in particular have seen dramatic change, positive change in terms of wealth in the last 20 years. India and China, mostly China. Yeah. So one could argue that they just bought their way to the top, right? By just making a hell of a lot of wealth, they fixed a lot of problems, maybe buried some problems too, who knows. So right now the biggest problems are still in sub-Saharan Africa and bits of Central Asia. That's the way it looks. And this graph you will see many times for many different issues. Most of the world's woes are concentrated in sub-Saharan Africa and to a lesser extent Central Asia. So the maternal mortality ratio, also called the obstetric death rate, is the other big thing that we like to measure at population health for the same reason. Right? So we like to think that we care about pregnant women, but we have a really hard time protecting them. Now, this is an interesting topic. I was struggling about how to broach the topic, but let's see how this works. So it's a portion of women who give birth during or shortly after pregnancy, who die rather, during or shortly after pregnancy. And again, traditionally we give it as a proportion of live births, but a percentage is fine as well. Almost all of these deaths occur in low-income countries, 99%. It is rare to find it in a wealthy country like Canada or the U.S., but it does happen here. Now, here is the big question. What is the biggest killer of pregnant women in North America? Yeah. No, it's not preeclampsia. And again, this is a controversial statement I'm going to make. This is reported by a couple of studies, and there are people who say the studies aren't accurate, but it makes a lot of media noise. Think about it for a second, and I'll get back to it in a bit. But preeclampsia is one of the biggest globally, right? Bleeding is one of the biggest ones globally. So I mentioned earlier that IMR and MMR are the biggest measurements of population healthcare system, and we talked about why that is already, right? Because they are preventable issues. And we think that we have solved that problem mostly in Western countries because of wealth that allows us to have a skilled birth attendant present, prenatal care, control of bleeding, all this other stuff. In poorer countries, they struggle with these issues because of often the distance to a local care center, the lack of availability of healthcare attendees. We talked about the barefoot doctors, right, before. So one of the things the barefoot doctors did was they were also birth attendants, so they really addressed that issue quite well. And by cultural practices, that's a vague way of saying some places have poorly trained midwives that do problematic things. So the midwife experience here, the midwife experience in other countries can be profoundly different. Here are some interesting numbers you might care about. So in Canada, the IMR is 4 per 1,000 live births. MMR is 5 maternal deaths per 100,000 live births, which is very, very small. But it never goes below that number. Like these are kind of like the basements for some reason, as opposed to Haiti, which is extraordinarily high numbers. So this is what we can aspire to for these nations, which are literally down the street from us. Lifetime risk of maternal deaths around the world. Developed countries, 1 death per every 4,000. Developing countries, 1 death for every 100 births, which is astoundingly high. I'm trying to look for China here. Where's China? There's China. No, it's not. Where is that? Yeah. So China has seen the greatest improvement in MMR in the last 20 years, and that's where these enormous global changes are having the greatest impact. Okay. Most MMR issues, once again, relegated to Sub-Saharan Africa and a bit of Central Asia. Did I skip that already? Oh, look at that. I skipped that. Okay, cool. Let's talk about that then. Let's go back to, well, I thought I had a slide here talking about that. 1 second. Yes, I do. Okay, good. Before I get there then, there are a host of indicators, more than I'm talking about here today, and you can spend some time going to the WHO database looking at endless numbers of indicators one could look up that are collected around the world. There are efforts to create more indicators. There's Center for Global Development, which is looking at more indicators as well. You can get the entire list if you care about this. Fertility rate, low birth rate, contraceptive rate, all this great stuff that relate to reproduction. As I mentioned, I did a study looking at female empowerment indicators, and the reason for that is, remember the Arab Spring? You guys are around for the Arab Spring? I don't know how old people are anymore. I can't. The Arab Spring was a few years ago. It was when certain Arab countries were in a state of revolution, deposing their tyrannical leaders. And we looked at the nations that had rebelled, the nations that are in the process of rebelling, and the nations that had not rebelled. And we looked at their quality of female experience. And the reason for that is there is some suspicion in the political science crowd that women were driving the revolutions. So what we found, after crunching the numbers for a large number of female empowerment indicators, including the number of women in the workforce, the rate of educated women relative to the male rate, how early they marry, how early they get pregnant, blah, 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 is this. Look at that. Straight line for the actual population ratio of women. So, in fact, the more women there were in a population, they're more likely to have rebelled, according to these very sketchy data. It's not a great study. It's just interesting. It shows the kind of fun things you can do with population level indicators. And this is interesting because it's actually counterintuitive, because historically, the more men in a population, the more unstable governments are. The more women there are, it usually has no effect. But in these countries here, the more women there were, they're more likely to rebel. So I don't know what that means. I mean, anything? I have no idea. But we publish it. That's all that matters. Okay. A word about relative versus absolute again. In poverty, we talked about it already. In epidemiology, I think I mentioned it, I'm not sure. But the MMR in Deonandia, let's say it's 620 deaths per 100,000 births, but that's based on 2 deaths. Should I be concerned about that? A realistic example is in Ontario, about 30 years ago, there was all over the media a big scare because the prevalence rate of cholera had doubled, right? So the Toronto Star was all over that shit. It was crazy. It went from 2 cases to 4 cases, right? So the doubling, that's a relative measure. The number of cases, that's an absolute measure. Which one to use? It depends. It depends on the story you're trying to tell. So beware of that. Always, I was taught by my first professors, always ask, what is the denominator? Or is there a denominator? Is this a fraction or is this an actual number? Okay, let's get to the thing I was talking about. There are some scholars, including this individual here, Don Stewart, who argues that our low maternal mortality rate and that of the U.S. are actually profound underestimates. That 5 per 100,000 is actually much higher than that. Why does she think that our number is an underestimate? And it gets back to the question I was asking earlier, is what is the biggest killer of pregnant women in North America? It's going to horrify you. Yeah? Not depression. Yeah, say it. Go on, say it. Oh, you Googled it. What is it? Murder. Murder by whom? Spouses, exactly. Domestic violence. Okay, so it is. So we do not consider the deaths attributed to domestic violence. And if we did, then maybe the numbers would be higher. I don't know. And this is based on a couple of studies. We don't know how much that actually changed the numbers, but it's an interesting thing to think about. Okay. We're going to talk about, how much time do we have? 6, we have time. Good. Let's look at another Hans Rosling video. Do we have time? We have time. Okay. Because Hans died a while back, and I feel we should look at all his videos when we can. It's the same video? Oh, same as last time, isn't it? Oh, screw that one. Sorry, Hans. So in essence, that video talked about life expectancy as a measurement of health. So we're talking about life expectancy now, the problems with life expectancy. Life expectancy is the time you expect to remain alive. It's a really problematic measurement because it's based on the previous cohort's experience. It may not refer to your experience because every generation is different. Usually every generation gets better. Who knows if that's still the case? Okay, so we usually give it relative to birth. So one of the important things to ask whenever someone says, well, life expectancies of this country are this and that, ask them, computed when, at what age? Life expectancy at birth is different from life expectancy at later in life. So think about it this way. This depicts it fairly well. This shows U.S. life expectancy computed in 1850 versus essentially today at different ages. So life expectancy at birth in 1850 was 40, meaning every child born in 1850 could expect to live to be 40. Today, you can expect to live to be close to 70 when you're born. It's actually higher than that now, but bear with me here. Why did that change? Life expectancy at birth. To understand that, you have to understand how these things are computed. What we do is we look at everybody born, and we see how long they live, essentially. Okay, but we already said that historically you tended not to live past your first birthday. So if you're all born today, you're also adorable little kids born today, and it's 1850, maybe 3 of you will survive another year. So on average, your life expectancy is minuscule small because the bunch that died in that first year are really lowering the average. So with every passing death, the remaining group is healthier because the weak ones have died off. So in general, the longer you live, the longer you're going to live because the weak ones have died off. If you look at life expectancy computed for the Canadian population, let's say, right, at birth, it's a certain number. Let's say it's like 77 or so. At age 2, it's like 78 because the ones who are very weak at birth have died off. At age 3, you expect to live to 80 and so forth. It keeps going higher and higher until 16. If I compute it at 16, it goes down again. What happens at 16? What did you do at 16? Yeah? They what? They get regulars in a certain way. Yeah? Driving in general. Right? So in Western nations, when you get your license, that's when you're going to die. So if you live past 16, you're okay. So just hold your breath to 16 and see what happens. Right? So we have this, as you get older, your expectancy is higher and higher and higher. 16 goes down again. And then, all the bad drivers have died off. And then you keep on going up, whatever, Now, this varies, of course, demographically. Different cultural groups have different experiences with violence and drug use and poverty and things like that. So in the U.S. population, in the U.S., black men do poorly at every step of the way until they get older, like over 50, in which case they live forever. So black men are more likely to be murdered, more likely to have all these bad experiences, but then they get through these rough patches and live forever. So old age homes in the U.S. are populated by two kinds of people: old white women and old black men, which is ironic as fuck, isn't it? I love that. So, but look at this. I think this graph really tells a story. So computed at birth, we go from age, at birth in 50, you expect to live to be 40. If I computed your life expectancy at age 80, at age 70 rather, you can expect to live to 80. Today, if I compute your life expectancy at 70, you can expect to live to about 85. We've gained nothing for the old people in 100 years. We've gained a lot for the young people in 100 years. So when people tell you the population is aging, what they really mean is young people aren't dying. That's what they really mean. Is our lifespan actually growing? A little bit, a tiny bit, not a whole lot, right? Maybe 5 years or so. That's going to change, I think, technologically speaking, very, very soon. We're about to have some revolutions in longevity. But all the gains made in the last 100 years, and this is the U.S. population, by the way. Europe looks very similar to this. Right? This is what Yemen looks like today in Chad. There's no reason to expect that Chad and Yemen, those struggling countries, won't look like this very, very soon. Okay? What changed to allow young people not to die as much? What made that difference? Yeah. In beating infection. How do we combat infection? Vaccine is a big one. What else? Yeah. General hygiene, huge, right? So clean water, not, shitting upstream, moving your toilets downstream, basic stuff. Right? Getting rid of standing water so mosquitoes can't breed. Good nutrition. General public health in general. Public health was a revolution that happened in the Western world about 150 years ago. We'll talk more about this when we do the demographic transition. demographic transition explains much about the way the world has changed and the way the world is going to change. And so I wrote an article about this at the Huffington Post earlier this year, and I got so much freaking hate mail. It's great. When I got hate mail, I know things are going well. And then, like, Al Jazeera called me to interview me about it, right? And I thought it was going to be like a text interview. So we're Skyping and talking about shit. And they're asking me questions. It's great. I didn't know they're recording the Skype conversation. So this becomes a broadcast, and it's seen by 15 million people. And I'd known I would have showered. I'll play it for you if you want later on. It's free. But like 15 million people about stuff I thought was obvious that we learn in basic demographics class, but for the rest of the world it's transformative. They're getting a lot of hate mail too. But the takeaway message from that is the world is transitioning from this stage to that stage. In fact, population sizes are expected to come down. We'll talk more about that in a couple of weeks when we do demographic transition. But it all starts here, thinking about how life expectancy is computed and why it has changed. It's changed because kids are no longer dying in the first year. That's all it takes. Okay. Here are the changes in life expectancy computed at birth in different parts of the world. So China's gone up, India's gone up, everything's gone up because of advances in preventing neonatal mortality. What happened there? Okay. So life expectancy does not distinguish how people died, only that they died. So you could have died of murder or of malaria or whatever it might be. It doesn't predict how long you're going to live. It just tells you the present state of affairs based upon previous experiences, right? Of the previous cohort. So it's a little bit incorrect to say that I can expect to live to be 87 because that's the average life expectancy in Canada. No, that's life expectancy computed at birth for the previous cohort. I don't know what my expectation is. I expect to live to be 200 personally. If I make it that far, the aliens will have arrived and I'll live forever. So you laugh now, you'll see what happens. Okay. The problem with life expectancy as a measurement for health is obvious. A longer life does not mean a healthier life. And we see that now with our quote-unquote aging population. And again, an aging population doesn't mean people are living longer. It just means we have more old people. So we have a lot of old people who are, not happy or suffering, etc. So maybe what we care about is a productive life, not a long life. What does productive mean? Sometimes we mean economically productive. And that brings us back to making decisions about who gets the health money this year. Is it the kids, the cooties, or the old farts for the old fart disease? I care about, as a decision maker, the kids because the old farts are not productive. Yeah, it sounds horrible, right? But that's the way things work sometimes. So sometimes we use something called the healthy life expectancy as opposed to the total life expectancy. So the healthy life expectancy is the number of years spent in good health, whatever that means, as opposed to just the number of years spent alive. Why is that blank? I do not know. Why is that blank? Oh, because I'm pressing a turn, that's why. Okay, let's change tacks a little bit now and talk about this thing called Qualies. We're going to talk about two measurements, Qualies and dailies. And this we'll cover again in epidemiology class, and maybe we've seen this already in stats class. But some people get Qualies and dailies confused. And one way to keep them straight is dailies are bad, Qualies are good. Dailies are bad, Qualies are good. Qualies are used usually for individuals. Dailies are used for populations. This is what they are. So the quality-adjusted life year, the quality or the quality or the quality or whatever you want to do it, is a way to add a quality adjustment to a year that's been lived. So I could argue that a year lived with a disability is not as great as a year lived without that disability. That's a problematic statement, I know. People would be, disability rights groups are very upset with that statement. I understand that. But population health scientists would argue that if you are injured and you can't walk now, but you could have walked before, the quality of your life has suffered. How do you measure that suffering? Back to a measurement question. So what happens is a committee is struck, and they decide upon a weight from 0 to 1 that will be applied to that year. So perfect health, that's a 1. Crappy health, that's a 0. Well, 0 is death. So how crappy was your year? Closer to 0, the crappier it was. So here's an example. A new heart valve saves your life. You're going to die, but now you're not going to die. You're going to live. But the heart valve hinders your quality of life because you're not as active. You can't run with your kids and play with your dog and all that stuff. So you're slightly unhappy. So how much unhappy did it make you? Do I have an example? I don't. Jeez. Okay, so a committee is struck, and they say the heart valve is worth 0.6 of a happy year. So suddenly you have a conversation with your doctor, and they're talking about whether or not to get the heart valve. He says, well, you don't get it, you're going to die. Okay, I get it now. How does that affect my quality of life? Well, you're going to live an additional 10 years now. You're going to die today, but now you live 10 years. But each of those years is only worth 0.6 of a good year. So in fact, you're going to live 0.6 times 10, or 6 quality-adjusted years. So sometimes decision-making around whether to offer this surgery or whether the patient is going to accept that surgery intervention is based around how many qualies does this give me? Yes? Yeah. Yeah, I mean, a quality doesn't apply there, but a different kind of measurement we'd apply there. There's a disability-adjusted life expectancy. The thing about qualities is they apply to individuals mostly. It's difficult to apply them to populations for decision-making like this. This is more about decision-making at the individual level, or at the hospital or clinical level, or at the level of funding that hospital or clinic. Like, am I going to put money behind this heart valve to make it readily available in the population if I know it's only going to offer 0.3 qualies? Okay. I'm not making any judgments here. I'm just pointing out this is a way of doing things, and that's what a qualie is. It's a tool to be used or not used, but it exists. That's what a qualie is, a quality-adjusted life year. Why do I keep doing that? Stop doing that, Ray. Okay, the daily is the most important one. The daily has changed the world. This is a disability-adjusted life year. And the reason the daily has changed the world is that prior to the daily, all we had to measure the impact of a disease was whether or not it killed people, or whether or not it exists, like prevalence. We had nothing about whether or not it makes you miserable. So the daily is a combination of years of life lost and years of life spent disabled in a population level. So maybe some infection kills a bunch of people, but it makes another bunch of people deaf. So how do I measure the impact of that particular infection on my population? Prior to the daily, we just measure the people who got it and people who died from it, but no combination of the death plus the suffering. So similarly, we have this thing called the disability-adjusted life expectancy, or the DAO. So Japan has a very high life expectancy, like in the high 80s, but their disability-adjusted life expectancy is in the mid-70s, because they've accounted for how much disability that population experiences, and they say that's equivalent to 74 non-disabled years. Okay. The thing about VALIs is that now we can include measurements of suffering, and that brings into play a certain category of suffering that previously got no play at all, and you all know what that is because it's every student talks about it endlessly now, which is a good thing. That, of course, is mental illness. So we now think that the most costly disease in the world, or the second most in a few years, is going to be depression, based on dailies. Without the daily, we'd have no way of measuring the impact of depression in the world. We couldn't compare it to, say, car crashes or heart disease, because it doesn't necessarily kill you. It sometimes does, but usually just makes your life hard. Okay. This shows where most of the dailies are experienced around the world. Unsurprisingly, Africa has the most dailies. Dailies are bad. Qualies are good. Dailies are bad. Remember that? So 5 of the 10 leading causes of global disability are psychiatric. And this is a growing area in global health, growing in terms of people acknowledging it and wanting to study it, but not growing in terms of people spending money on it. So I know a lot of students want to apply their careers here, and that's great if you do, but be aware it'll be a hard road because there's not a lot of funding or appreciation for it. One of the problems is defining mental health issues varies from place to place. And not everyone agrees. Like, I'd work in Trinidad in mental health, and there, if you can feed yourself, you're fine. That's a criterion, really. Right? You can be shouting at the world, living in a box, but you're fine because you can still feed yourself. So our threshold for what's considered mentally ill varies from culture to culture, and that's a real problem. And we have a hard time measuring the prevalence. Like, it's a real ordeal measuring prevalence of mental illness, and no one has a good idea how to do it yet. Social media is one of the new tools that's coming into this. So there are new Twitter mining tools that look at certain keywords people are tweeting all the time. I had a student last year who did a study. He mined Twitter on the university campus for a year to determine the peaks and valleys of depression-oriented tweets, and found they actually correlated well with exam period. Not surprising, but it's a struggle. So right now, this is 1999, but the rank hasn't changed all that much. The current burden of global disease in terms of dailies: number one, acute respiratory infections, AIDS, prenatal infections, diarrhea. Right, depressions makes the top 5. Not surprising. We think. Let me see. Comparing mortality and dailies. So heart disease kills you the most. Respiratory infections has the highest dailies. Cerebrovascular disease, so strokes, will kill you the second most. Diarrhea has the most dailies. So prior to the dailies, we would think these would be the most serious things. Now we think these are the most serious things. So the tool we use to measure matters, has an effect on how we view things from a policy lens. Stop doing that, Ray. Stop creating blanks. Okay, I made this slide years ago, and now it's almost 2020, and it's coming true. This is the way things almost are now. So we think in a couple of years, and we're pretty much there now, the number one most burdensome disease in the world will be heart disease, not surprising, due to poutine, due to obesity and diabetes and other issues. Number 2, depression. 3, traffic injuries. A lot of people miss that. Traffic is a health issue. So, students would travel all the time. They tell me, Ray, what kind of vaccine should I get? Vaccines are important, but just look both ways before you cross. And don't rent a motorcycle. Right? I drive a motorcycle. I've crashed it twice. I don't recommend it. Don't do it. don't do as I say, not as I do. And so that's what's going to kill you, traffic injuries. So be careful. Violence has entered the conversation now, domestic violence, self-inflicted injuries, that's entering the conversation. So we think the global projections for disease cause in terms of deaths, cancer is around the increase, ischemia, heart disease, stroke is on the increase. These are interesting, right? Because these are different from HIV and TB and malaria, which we think are going to decrease. Do you see a development trend here? Is there a narrative coming out of here? What is it about cancers and strokes and heart disease that are distinct from malaria and tuberculosis and HIV? Back there? Oh. Yeah, that's one very key observation. There's a second key observation. Yeah. Yep, they're infectious. So third observation that rounds out this entirely, yeah? They might have always been top. We weren't measuring them, but you're kind of getting at it. So, what kind of societies suffer from these versus these? There's a wealthy societies, developed societies. So the world is heading into a new paradigm where we're entering into a situation where the health crises that the world faces aren't these old killers necessarily, the things that dominate the Sunday afternoon infomercials, even though they're still around, they're so important. These are the things we talk about. Okay. So India is now seen as probably the home of breast cancer. That's going to be the biggest cluster of breast cancer in the coming years. And that's shocking some people. They never thought of India as being a breast cancer nexus, but it really is. And one of the reasons is they've fought back a lot of the infectious diseases, and now these are emerging to the forefront. So what we're seeing here is an epidemic, but it's also an epidemic of wealth or of development status. And this has to do with something we call the epidemiologic transition, which we'll talk about in the future as well. Okay, I'm running out of time, so I'll skip through. This just shows us how things are going to change in terms of dailies. Screw that. Okay, we're almost done here. So one of the challenges here is in choosing and defining the appropriate indicators to tell the story we are trying to tell. Right? The daily came around, allows us to tell whole new stories. Who knows what's coming around the corner in terms of tools we can apply. Choosing the right indicator is critical to telling the right story, and choosing the wrong indicator can really skew the narrative. And our jobs as consultants or as scholars or as policymakers or as researchers is to tell the right story to the people that matter. And it's a bigger, more difficult task than you can imagine. Numbers are collected in different ways by different people in different countries. If you go to the WHO or UN websites and collect those indicators, they're not all collected by the same people. Like the maternal mortality rate in this country is not collected by the same people as that country. In fact, it may not be even collected by the governments. It could be some NGO just shows up one day and does a study and donates their data. So data quality is a huge issue around the world. We assume we have a good sense of what's happening. We really don't. And many, if not most countries, do not have the infrastructure to collect the numbers accurately. So there are big, gaping holes in the global landscape of knowledge. To fill that gaping hole, we have this thing called surveillance. In the EPI class, we will talk a lot more about surveillance. I'm just going to mention it here. Surveillance is one of the key tools in disease maintenance and population health in general. It's one of the infrastructures of global health. What it is a systematic way of keeping track of the presence of disease. And here in Canada, we have a host of surveillance systems, automated, that are quite advanced. Every time you go to your doctor, whatever he or she writes down, that's entered into a surveillance system. Some of it's mandatory. There's some diseases, we call this the Notifiable Disease Registry. If they see smallpox or chlamydia, the government must be informed. Right? Not that it's you necessarily, but there was a case of it so that we have a perfect reckoning of the burden of these diseases. We have strong surveillance systems around suicide behavior, around naughty kids, seriously, around seniors' falls, around any number of things. Americans have hundreds of surveillance systems, hundreds. Poor countries have almost none. So I had to create a surveillance system for tuberculosis for a particular country that had none, and we had no money. So I created a really skeletal one that ran like this. So this is in Guyana. So there was a federal office that kept track of TB that reported to the government and the donors, the World Bank and SEED and all those places, and but they didn't go into the field. So we created a form. It was a form, literally a piece of paper that had like 3 sections on it, and you fill out the same information for each 3, and you rip it in half, and a kid runs it down the road to another office. That's how basic it was. Okay, but that's all it takes sometimes. So if someone walks into this clinic and a local place, they would keep a copy of the form. Another copy would be sent up to the regional office, and they would take a copy and send the third copy up to the national office, who would then collate all the information and then redistribute it to everybody else. So everyone knows what's happening nationally, and the national body knows what's happening regionally. And they can turn report to the international donors accurately about the burden of tuberculosis. The system lasted like a few months until we had like an electronic system in place. But sometimes all it takes is something very basic. Like some countries have surveillance systems that are even more basic than this, like little kids handing off scraps of paper to other little kids running across sand dunes and stuff like that. But you do what you got to do. That is surveillance, my friend, and that is the end of today's lecture. Thank you very much.